Well, thank you very much, and thanks for inviting me to come and talk to you. And I would completely echo what you've just heard, and I'm not going to take you through healthcare as a system. But I want to talk to you about something a little bit different, particularly around, what is a medical director for, and what do they think about? And one of the things that intrigues me about the health system, and I can ask you a question in a second, is it's writ pretty large through the health and social care bill and lots that we've heard about already this evening, that quality is the organising principle of the health service. How many, just to a quick straw poll, how many of you have had any formal education on quality? That's a bit odd, isn't it? You are the self-selected leadership group by the fact that you're here this evening. Many of you, I suspect, have already got degrees. I suspect you're a variety of years in your undergraduate medical training, and unless I missed a hand, none of you have had any formal teaching in what apparently is the underpinning principle of the health service. How many of you have done the anatomy of the heart? Yeah, since when was the anatomy of the heart the underpinning principle of the health service? And so what I think we need your help with, I have a strong belief in this, is that we need your help in changing the model. Because if we spend our lives, and you'll come on to spend your life, educating the future generations of students and doctors in training, and we don't grasp the fact that there's a mismatch between what the NHS thinks it's there to do, which is deliver high quality care, and we spend no time having a discussion and having education about what that means for the people who are actually going to be delivering it, that we've got an absolute mismatch between the expectation of the system and the education that you have. And let's just break down quality for a second, and it breaks down pretty easily into patient safety, patient experience, and clinical effectiveness. And I don't know how many of you will have had much of experience of the wards yet, but let's take patient safety as one of those markers. Let's take one aspect of patient safety and see what you think about this. What's the commonest and perhaps most dangerous allergy that patients potentially exposed to in hospitals? Shout it out. Penicillin. Right. Everyone knows penicillin. Allergy is dangerous. And we have systems. You heard a bit about systems. We have protective systems. So we will, how many times have you had drummed into you, ask about the allergies when you clerk a patient? And make sure, if it's penicillin, preferably write it in red, and it gets written down on the drug chart, and all the junior doctors know about it, the nurses know about it, and the pharmacists know about it. Right. Now, so everyone knows about it. How many people in this room will take a bet with me for £10 that there will be no penicillin allergic critical incident in a hospital in London this year, in the next 12 months? Anyone willing to go? Everybody knows, everyone knows about it. Every doctor, nurse, pharmacist, everyone in a hospital knows about it, but no one's willing to take a bet. So what does that say about currently our understanding about patient safety? If the most common, the most known about adverse event that happens to patients, you will know, and then you absolutely believe it's going to happen. So that tells us in microcosm that we've got to do something, and we've got to do something with your help, which is to try to dissect. And most, I think that in running a hospital, running a department, running a service in a hospital, it's a bit like looking after a patient, really. And you can think about the pathology of organisations and about the pathology and the understanding of the pathophysiology of systems. So there must be something pathological, and we have to understand the physiology of that, such that we're running a system where everybody in this room knows that someone in London is going to have a serious adverse event and possibly die from a penicillin allergy this year. So I would argue that in the new NHS, building on Grace's talk, is that we have to ask you to, as forensically examine the quality issues in the system, to study what does quality mean. And there is a science behind improvement, how you improve quality. And to start to say to some of your educators in your medical schools, hang on a sec, I've had 3 lectures on the mitral valve. I've had no lecture on the systematic way in which we prevent harm from serious untoward events such as penicillin allergy. How do we do that? How do I take a personal responsibility in doing that? Now, each of you went back to your constituent universities and saw the Dean of Studies and said, I want to see in the first year lecture program a lecture on safety and quality improvement. You would radically change what we would be hearing, I think, from your successors in 5 years' time. Because it can't be right that the very people who are going to be delivering healthcare for the next 30 years have had as yet no formal education in it. So that takes me to the second issue, which is about leadership. And it's very interesting, the other thing is about a medical director that happens with your colleagues. I don't know if even being a medical student who's interested in leadership, how many people have been told they've turned to the dark side already? And that there's something wrong about doctors, that there is something wrong about doctors taking the challenge of leading their profession and their organisations. There is absolutely nothing wrong with doctors taking a role in running organisations. There is strong evidence, there is strong evidence that clinically led organisations perform better than non-clinically led organisations. So I think the second point I would make to you after quality is about leadership, and to continue the path that you've already started just by the fact that you're here this evening, and taking roles as early as you possibly can. You don't have to wait till you've got grey hair or not much hair. You don't have to wait, because you can take a leadership role from anything. So, at an undergraduate level, start to get involved in the way that your curriculum is set in the universities. Get quality onto the agenda. Take a leadership role as soon as you're a junior doctor. Get into the junior doctors' leadership groups in the organisations that you're working in. Take a bit of flack that you've gone to the dark side early. But that's great. Go over there and embrace it. Because it's only by embracing that that ultimately you can make a difference. Because I strongly believe that clinician leadership is at the heart of the new NHS. And then I think the third thing I would just talk to you about is about behaviours. And I think it flows from leadership, but it flows from one of the other greyboard up, which is about start to understand variation. To be honest with you, I could not stand statistics when I was a medical undergraduate. But actually, starting to look at variation and starting to look at data is very important. The one thing I think I would also say to you, I think you should be a quality-driven cohort. I think you should be a leadership striving cohort. And I think the other thing is you should be a data-driven cohort. Is that you should embrace the power of data. Unfortunately in medicine, a lot of the times you'll hear opinions. You'll hear people tell you stuff because they believe it to be true. And that often, their opinions drive their behaviour. So, I mean, I can well remember sort of 10 years ago being told that there was a background rate of MRSA that was just inherent. And actually we just accepted it. And actually, you know, hygiene, hand washing, those sorts of things made no difference. But actually, looking at the data, looking at quality improvement, rapid improvement cycles, actually makes a difference. And now MRSA is becoming vanishingly rare. It's been 200, it was a bad thing to say, it's been 220 days since we had an MRSA bacteremia at Guy's and St Thomas's, a big organisation. So start to examine the data, both in terms of your own organisations. Look at the data from your organisations. Look at the data in your service. When you work in a service, start to look at the data that your service is generating and say, is this good enough? And then start to look at a macro level at variation across hospitals and across geographical areas. And start then to ask the questions, what can I do to make a difference? So measure things. So I think my observations on the NHS, the things that I think are important for you are embrace quality, embrace leadership, and embrace data. And I think those are my 3 take-home messages. I guess we'll get some conversation a bit later on if we have a panel, but I'm happy to take questions then, but thanks very much.